Good afternoon or good evening. Welcome to our fourth international webinar, COVID-19, Organ Donation and Transplant Town Hall. I'm Emily Blumberg, past president of the American Society of Transplantation and a professor of medicine and infectious diseases at the University of Pennsylvania in Philadelphia, Pennsylvania. I'd like to welcome you on behalf of our group of international transplant organizations shown on the next slide. Next slide, please. This includes AOPO, AST, ASTS, CST, ESOT, ISHLT, NATCO, TTS, and UNOS. And I'd like to especially thank our organizing committee shown on the next slide, which includes members of all of these organizations. Today, we will be joined by my co-moderator, Dr. Deepali Kumar from the University of Toronto, as well as an outstanding group of speakers. We've divided these sessions into two groups. The first, I will tell you who all the presenters are, and then after they speak, we'll have a little bit of time for some discussion. Dr. Kumar will then take over and introduce her speakers and again have discussion at the end of that session. So without further ado, I'd like to tell you who will be speaking in the first half of this webinar. The first half is going to focus on what happened to transplantation during the COVID-19 pandemic. And Dr. David Klassen, the Chief Medical Officer of UNOS, will be presenting the United States perspective. And Professor John Forsythe, the Medical Director of the NHS Blood and Transplant in the UK and past President of ESOT, will present the UK experience. Next, we'll be hearing about what happened to the waitlist and outcomes during the pandemic. And our first speaker will be Dr. Lloyd Ratner, Professor of Surgery and Director of Renal and Pancreatic Transplant at Columbia University New York Presbyterian Hospital in New York City, New York, and the past president of the American Society of Transplant Surgery. Our second speaker in that section will be Professor Patrizia Burra of the Multivisceral Transplant Unit and Gastroenterology, Department of Surgery, Oncology, and Gastroenterology in Padua University, Padua, Italy. And our final speaker in the first section will be Dr. Michelle Jesse, a clinical investigator and psychologist at the Transplant Institute, Director, Resident Research in Internal Medicine, and an adjunct research scientist at the Center for Health Policy and Health Services Research at Henry Ford Medical Group in Detroit, Michigan. And she'll be speaking on the impact of COVID-19 on the workforce, the challenges of burnout. And so we'll now start with Dr. Klassen's presentation. Thank you very much and welcome.
Okay, thank you very much, Emily. I want to thank you personally and all of the other organizers of this event. I think it's a particularly useful event in getting the worldwide perspective that I think is very valuable for all of us to understand. What I want to do is give the US experience in terms of transplant numbers, donor numbers, waitlist activity. And I particularly want to look at where we are in the context of the current state of the pandemic and how it's affected us and what we might expect going forward, I hope. This next slide here shows the COVID-19 new cases by country. And I think it's, again, this illustrates that this is, as we all know, a worldwide pandemic. And it's interesting to see how the cases really kind of parallel each other. And this shows cases in the United States, in South America, Brazil, South Asia, Europe, and the United Kingdom. Could I have the next slide, please? This actually focuses just on the United States cases, and these are the new cases as they have occurred. What you can see is that the initial wave or pandemic began in March of this year, and by current numbers actually was relatively modest, although that's when the most profound changes to the transplant system occurred. There was also a second wave in July and August that in terms of United States effect on national transplanted donor numbers, really didn't affect numbers terribly much. And then you can see right now we're in the midst of a really an exponential rise in new cases, and it remains to be seen how that will affect us and how we will all respond to those challenges associated with that. Could I have the next slide, please? This slide again shows really the history of what's happened to donor transplant numbers, deceased donor transplants in the United States. This is going back to February, and you can see really starting in March, there was a profound decrease in the number of deceased donor transplants, most notable in kidney in the blue line at the top, but also seen in all of the other transplanted organs as well. Kidney transplants decreased by about 50%, deceased donor transplants in early March and April. But then gradually recovered, and we're back to close to normal, although not quite, really by June. Although it's not apparent, actually the organ that was affected the most was lung transplants at the bottom, and they decreased by almost 3/4 at that time. Next slide, please. Really what was most profoundly impacted was living donor transplant numbers. And what you can see here is that there was a very, very rapid and profound decrease in living donor transplants in March of this year. And they nearly ceased across all parts of the United States. I think they did gradually recover and now are being done in relatively normal expected numbers across the United States. I think perhaps as we go forward, though, it would be useful to keep in mind these living donor transplants as potentially an early and sensitive indicator of a response to the pandemic. I think living donor transplants, are optional, are to a certain degree elective, and are really dependent on hospital resources and the staffing resources within a given transplant center. Next slide. This is a fairly complicated slide, but what this shows again is waitlist additions. That's the green line across the middle part of the slide. It also shows inactivations by week, and what you can see again in March, there was a spike in waitlist inactivations. Those are the blue lines there that represent COVID-specific waitlist inactivations, and that was brief, but still is occurring to a certain degree. I think what is most interesting here is actually the decline in waitlist additions, and you can see that was a more gradual decline, but then it also has not rebounded completely. Although just in the last month, perhaps, we're back up to normal levels. I think, again, this sort of slow, gradual increase in waitlist additions maybe is a different sort of indicator, perhaps reflecting the responses of the healthcare system more broadly defined, since waitlist additions requires referral and an interaction with the broader healthcare system. So I believe this also might be something that is worth monitoring as we go forward into this kind of new phase of the pandemic. Next slide. This is the year-to-date cumulative deceased donor transplants in the United States. And actually what you can see is that the numbers are relatively robust, at least compared to last year. And in fact, deceased donor transplants are a bit ahead of last year. That is somewhat surprising, although there probably is a certain degree of lost opportunity that will not be recovered. I think we were heading probably toward at least a 10% increase over last year, but that will not likely be realized this year. Next slide. This is year-to-date living donor transplants, and you can see living donor transplants were much more dramatically affected, and at this point still have not recovered completely with respect to what was seen last year. It remains lagging behind. Next slide. And then combining both the deceased donor transplants and the living donor transplants, you see here the year-to-date cumulative transplants, and really it's about exactly what we saw last year. You might argue that this looks pretty good, and you can say it reflects the sort of the robustness of our system. However, also, I think these sort of high-level data that we see here really conceals a certain important degree of heterogeneity that is not apparent, and that really, I think, is there is geographic concealed within these data are geographic heterogeneity, organ-specific heterogeneity, and also some heterogeneity with respect to the impact on different populations of recipients as well. And I'd like to kind of go through a couple of some examples of that. Next slide. This is the year-to-date transplants in the Northeast United States. Clearly, this was the area of the U.S. that was impacted, I think, most severely and most directly in the beginning of the pandemic. And their numbers in the Northeast really have not recovered to what was expected or what occurred last year. Next slide. This is a little bit of organ-specific data, and I think, again, lung transplants, although they're done in relatively fewer numbers compared to some of the other organs. Again, this was the organ most dramatically affected, and the numbers lag behind last year by a significant amount. I think given the nature of the COVID-19 infection as primarily manifested as a pulmonary infection, I think this is not surprising. Next slide. Within the groups of recipients, the pediatric population in the United States, I think, was hit really significantly differently compared to the adult population, and pediatric transplants also lag behind. I think pediatric transplants, and in terms of overall numbers, driven largely by kidney transplants, are really more dependent on living donor transplants, and I think that is largely the reason for this significant change here. Next slide. It's been an important issue about minority populations. I mean, it's been well described that minority populations have been dramatically impacted by COVID-19 infections across the United States. Within the world of transplantation, it's not exactly clear how that has played out. Looking at these data here, cumulative transplants to date by race, by Black race, you can see that the numbers actually are very similar to last year. I think that this is something that we're actually looking into in a much deeper way currently at UNOS, and we'll have some more granular data on that. Next slide, please. This is actually a little bit more detailed data on minority populations and the impact of COVID-19. This is actually, I want to thank the SRTR for this data. These are data from the SRTR website. These are all publicly available there, and I think they're pretty instructive. This is kidney transplants by race. You can see in terms of total transplants, all the racial groups here listed, white, Black, Asian, and other, had significant impacts. I think it looks like the white population was impacted fairly dramatically, and they also make up the largest number. I think if you divide it by deceased donor and living donor transplants, it provides a little bit more insight, and I think the next slide has some of that, some of these data. This is, I guess this is the deceased donor kidney transplant, and this slide it's by transplant rate, which is transplants per 100 person years. And you can see all racial groups were very significantly affected at the time of the start of the pandemic in March and April. And you can see that these data there. The rebound was relatively quick and seen across all racial groups as well. Next slide. This is living donor transplant rates by race. And again, you can see the profound impact really on white race, but also on all other racial groups as well. Next slide. Waitlist mortality has been something that is a bit difficult to study. It does take time to accumulate this sort of data. This is, again, from the SRTR website. And I think this is pretty instructive here as well. What you can see is that minority populations were dramatically affected, I think, at least transiently, in terms of waitlist mortality. The white population was less affected. I think, again, this probably reflects as an indicator, the impact on the healthcare system a bit more broadly, in terms of what's happening in dialysis units and what's happening in the broader population as well. This also might be something to watch carefully as the pandemic plays out. I think that's my last slide. In terms of these indicators, I looked just earlier today at last week's number, and there was a significant decrease in registrations as well as transplants and living donation last week. But actually, I think when you think back, that reflects the holiday week across the United States, and so those data are really an anomaly. But it is something to watch carefully going forward. So I think, my take on the U.S., on the impact in the U.S. is that it was dramatic early on. The system recovered, resources were put into place, and there's been a steady recovery since. And it reflects some stability in the face of multiple waves of infection, actually. And I think, however, with the rapidly rising numbers, I think, vigilance and anticipatory sort of planning is the order of the day. So I will stop there. Thank you.
Great, thank you. And next we'll be hearing from Professor Forsythe.
Emily, thank you very much indeed. And can I just thank you for the invite, you and the organizing committee. I'm already struck by some of the similarities with David's presentation. I guess I go into the mechanics of it a little bit more, but I'm already struck by the similarities, but I'm sure we can learn from each other. And I'm grateful for the international reach of this webinar. So I guess some context to begin with. I just looked at the Johns Hopkins website today, saw that worldwide there are now approaching 64 million cases, 1.5 million deaths. The context of the UK, we are 9th in the league table of international league table of cases, where nobody wants to top that particular league table. And that means we have about 1.6 million cases, 60,000 deaths. So by my math, that means that there's been 1 death per 1,000 population. Next slide, please. So if we take our minds back to March 2020, we didn't know an awful lot, did we? We weren't sure whether SARS-CoV-2 in our waiting list patients, if we continued doing what we normally do, whether we would open them up to increased risk. We weren't even sure whether we would transmit the virus with donor organs. And we certainly weren't sure about the safety of our workforce. Next slide, please. Next. Yeah, thanks. Most of you will know we have a very centralized, or at least in terms of funding, commissioning and planning, public health service in the UK, the NHS. Now this has drawbacks, but in the context of the pandemic, there are significant benefits. We have the UK Transplant Registry, a very complete registry of waiting list patients across all organs and transplant follow-up. We also knew quite early on in the pandemic about all patients who had a positive test, all positive tests. And we also knew in a separate registry about deaths associated with COVID. Now, in a process that would normally take at least 3 months or 6 months to join all those registries together, actually in a very few days we were able to put the registries across to speak to each other. And because of that, and next slide please, we were able to publish this national cohort study. It was submitted in June and accepted shortly thereafter for publication. And I pay tribute to co-authors here, where we were able to have a very complete cohort study of all patients on the waiting list, or those who had been transplanted, who had contracted COVID and then went on to be monitored. And I'll come back to that study in a moment. And I'll come back to the authors of this study as well. Next slide, please. Now, Ken Galbraith was an economist who worked with JFK, and he's probably one of the most quoted. He was a walking aphorism. Next, please. This is one of his aphorisms, that meetings are indispensable when you don't want to do anything. Now, actually, in the context of this pandemic, that wasn't true for us. Those people that you saw on that last slide in that article, we met on a very regular basis across all organs, across the whole of the UK, and we also had lay, member and patient involvement in that group. And because of very regular meetings, we carried out a number of major actions. We counted, I think recently, about 52 actions that we took to try to manage the pandemic and donation and transplantation. Next. As a for instance, we early on carried out donor testing in all donors, and as the rapid tests became available, we rolled out those tests. With a heavy heart, we actually reduced the number of donors we attended across the UK because we felt that we needed to focus all our efforts on those donor organs which we knew were actually going to be transplanted. Next, please. Retrieval is also centrally organized, so we were able to check on and boost, if necessary, capacity across retrieval in the UK, and we were able to make small changes such as the transport of the retrieval teams. One of the most important things that we did was the clinical team was able to regularly update centres and patient advice and put that on our website, and that I know was heavily used. Much as David has just said, living donation was really badly hit in that first surge. It largely stopped in April, with all but 3 of our renal transplant centres closed, restarted in August. And MR here stands for matching run. We were actually able to start the matching run of our kidney exchange, which of course requires that a number of centres across the UK are active and fully active. The matching run was restarted in October. Next, please. So all of the time we were amassing data, and the data, and remember this is a very complete data set, and we were able to demonstrate that the incident and subsequent death of patients on the waiting list or post-transplantation with SARS-CoV-2 was relatively low in incidence, although the risk of death, if you did contract SARS-CoV-2 as a transplant patient, and that was mainly in patients who had been transplanted some time ago, was 25%. SARS-CoV-2 infection more likely in the associated with the factors that you see here in the 3rd bullet point. And the only independent associated variable was age. And I guess we've seen that in quite a lot of COVID publications since. Next slide, please. So this is the bang up-to-date data now. So this is just from very recently, and you'll see in the top blue line that the number of positive transplant recipients in this registry, you'll see the first surge as the sort of exponential growth, the plateauing, and then the second surge. And hopefully we do feel, hopefully in the UK now, that we have plateaued out at the top of the second surge. In the green line, you'll see the equivalent waiting list patients. And similarly, for the same 2 groups of patients, the patients who sadly have died associated with transplantation or waiting list. And of course, this is very important because it allows us to describe the competitive risk between waiting for an organ or receiving a transplant, which helps us to answer questions for our patients. Next slide, please. The second surge, we started planning in August, and we wanted to leave a level of local flexibility. But the difference here was that we wanted to minimize any closure, minimize any reduction in transplantation, and largely we've been successful in that. Waiting list management, we have seen collaborative effort amongst all centres with advice going back and forth in terms of those patients who should remain active on the waiting list. And indeed, we have seen organs that have been allocated to a particular patient, and that patient move from centre to centre to allow that transplant to go ahead for that patient. We have also bolstered the organ retrieval service and kept capacity at full level. We continue to monitor data, but we also monitor centres, and in fact, we've found that our clinical teams have often turned to us to ask for help in dealing with a particular hospital to point out the priorities of donation and transplantation against the competing priorities of that hospital. Next slide, please. And I think this picture tells quite a bit. So on the black line is the number of transplants, and the blue line the number of donors, weekly numbers over the last number of months. And you can see that on average, there are around 30 donors per week in the UK and around 80 transplants. And that's normally in a percentage of about 40% of DCD in any 1 week. Next. And you can see the effect of the first surge. The first surge, we were largely for a couple of weeks really only transplanting the most highly urgent liver and the most highly urgent heart patients. Kidney transplantation, much as David has just described, was curtailed for a short period of time. Next. But I think we were really very pleased with the response that we saw, the V-shaped response that we saw in terms of July actually was the best July in terms of donor and transplant numbers for a decade, and August was the best August, given that that is our summer holiday period, the best August on record. So a really quick bounce back. And a bounce back towards more normal discrimination between DBD and DCD, which had almost largely been only DBD during April and May. Next. And then we see the effect of the second surge. We see that during October and November, there was a plateauing out of the number of donors and also the number of transplants that happened. But as I've said to you, we think that we are now at the point where the second surge is largely over. The most recent figure that I have from just a couple of hours ago was of 66 transplants. So hopefully a climb back up towards our more normal figures. So Emily, again, thank you for the invite. I hope that I have demonstrated not only some of the figures which match to a certain extent those that David has just demonstrated, but also some of the mechanics that went behind this in perhaps a system that is a little more centralized in the way that it is run. But just to pay tribute also to the whole team across donation, retrieval and transplantation who allowed this to happen, because I think in February or March I would have undoubtedly accepted these figures given what was facing us, but also to pay tribute to donor families who at a time of tragedy in their lives and at a time when they were separated and isolated from their loved one who was dying, they still allowed the Altruistic Donation Act. So thank you for that.
Very much. And now we're going to turn to talks about the waitlist and outcomes. And our first speaker will be Dr. Lloyd Ratner.
Great. Thank you, Emily. I'd like to thank everyone who's listening. You know, when Emily and I came up with this idea in the early springtime about having these webinars, we didn't realize that they'd get as good an audience and as response speakers and all as they've gotten. And a lot of the credit goes to Emily and the rest of the organizing committee. I'd like to shift gears a little bit. We heard from Dr. Klassen and Dr. Forsythe sort of about the macro. I'm going to talk a little bit more about the micro in terms of the impact of the pandemic surge on patients waiting for renal transplant, basically giving the experience from here at Columbia in New York City. Next slide, please. So we all know that much has been written on the impact of COVID-19 on transplant recipients, but there's been really very, very little data on the impact of the pandemic for those people who are waiting for transplantation. And I was also very surprised to find, as I keep looking for data, that there's almost no data on the impact of the pandemic on the end-stage renal disease population. Now, our program, like most of the other programs in New York City, curtailed doing transplants in the spring in mid to late March and didn't resume doing transplants again until May. And in fact, our renal transplant program was completely shut down in terms of performing transplants. We were still evaluating patients and obviously still following patients. And when we were considering reopening, there were a lot of practical considerations that we started thinking about in terms of what happened to our waiting list and what was their readiness for transplantation. And so we endeavored to find out. So next slide, please. So we actually did a survey of all the patients on our waiting list. And what we wanted to know was how many were tested, how many got infected, how many died, but then also things that would impact their readiness for transplantation in terms of how many lost their jobs and lost their insurance as a result, how many lost their social support or transplantation. So very practical things as we were trying to, reopen our program and pick the patients, for the limited available organs that were there. So we got an IRB approved study, and this was a retrospective survey. It was a structured telephone survey that was conducted between April and June of all our adult patients that were active on the waiting list for both kidney transplants, but also kidney pancreas, pancreas alone, and pancreas after kidney transplants. And interestingly, during this time, Columbia University, in response to the pandemic, moved up the graduation date for our medical students. So our medical students graduated, but then they didn't have jobs, they didn't have licenses, and they didn't have anything to do, but they were newly minted doctors. So we enlisted them to do these structured telephone surveys. So we had people who actually, knew quite a bit of medicine and could answer questions when they called patients and all that. A lot of the work of designing this study and overseeing it were done by Gretchen Boyd, who's one of our chief clinical coordinators, and Dimitra Tsepepis, who's PharmD and head of our transplant quality initiative. Next slide. So these are the structured questions. Have you been hospitalized since January 1st, 2020? Have you had any other illnesses or other changes in your medical condition since January 1? Were you told by a provider that you have or had COVID-19 disease? Did you have a COVID-19 test by PCR swab? Did you have any known COVID-19 exposures? Are you currently employed? Are there any social support changes in your life? Are there any changes in your transportation access, specifically with getting to the hospital? Are there any changes in your insurance information or coverage? And does the patient, and then the surveyors were queried about, does the patient need a visit with any of the following, which included the physician, a surgeon, a nephrologist, a financial coordinator, a social worker, etc., all the components of our transplant program. Has dialysis information, that should be the electronic health record, been confirmed or updated, and does the patient need to be placed on internal hold or temporarily inactivated because of COVID? Next slide, please. So at the time, we had 433 active patients active on the waiting list. We had about an equal number who were inactive at the time. We were unable to contact 5 patients, so 428 were contacted. Only 78 patients, or 18%, were tested, and that reflects the availability of the testing in the early spring, where it just wasn't that available. So of those, 37 or 9% of the total tested positive, and another 39 patients tested negative. Next slide, please. So we found that there were, during the survey, we had 7 patients who died from, that we found out died from COVID. There were an additional 2 patients that we knew of who died before we commenced the survey. So in all, 9 patients died from COVID on the waiting list, 2.1% of our active patients. 69 or 16% were tested for symptoms, and again, 7% or 30 patients tested positive in addition to the patients that died. 16 of those 30 positive patients had a known exposure to a COVID positive individual. The rest don't know how they were exposed to it. Fortunately, and we were very pleased about this, only 1% of the patients reported losing their social support, transportation access, or insurance coverage. But we did find that as a result of the survey, additional follow-up was scheduled with a physician for 30% of the patients, a social worker for 30%, and a financial coordinator for 42%. So there were issues and problems going on that we picked up on this survey, but didn't necessarily require inactivation. Next slide. This shows the highlighted in yellow are the differences in terms of those that tested negative and tested positive that were statistically significant. You can see the things that were statistically significant were male gender, diabetics, and the amount of time on the waiting list. And approaching statistical significance was Hispanic ethnicity. Next slide, please. So this is a map of New York and New Jersey in our local area, and you could see the cluster of our waiting list. Where you see that large cluster, that's around right where our hospital is, but it's also a lower socioeconomic, high density, largely immigrant Hispanic population. And so not surprisingly, because of the high density, those were the patients most prone to test positive. So I think it was more a reflection of their socioeconomic status and density rather than Hispanic ethnicity that resulted them in testing positive. Next slide, please. So during this pandemic and during the surge, there was a lot of risk mitigation going on. And I think one of the things that is likely is that we have an underestimation due to the limited testing. But There were a lot of operational changes at the dialysis units in New York, where they developed COVID positive specific dialysis units. There were extensive public service announcements and communications. There was a daily briefing on TV by the governor. Our program itself fielded over 100 calls per day about patients inquiring about both waitlisted and transplanted patients inquiring about what they should do in terms of the pandemic. The patients reported being very proactive and responsible in terms of masks and social distancing, and many of them stated that they felt scared or that they were doing everything possible to stay away from others and stay at home. And in terms of the loss of jobs and loss of insurance, it turns out that most of our patients weren't working pre-COVID, and we had a very high proportion of Medicare coverage, so they couldn't lose their jobs or lose their insurance coverage. Next slide, please. So in conclusion, this represents a single urban center experience. The pandemic surge actually, fortunately, had limited impact on our waiting list readiness. The findings probably are not generalizable, but there are lessons to be learned. And I think the risk mitigation strategies appeared to be effective. Lower socioeconomic, high density, diabetics, males, and individuals with known exposure seem to be at higher risk. And I think it's important to continue active waiting list management during surge. And I'll end there. And again, thank you for your attention, and thank you for the other organizers for allowing me to present.
Thanks very much. And now we'll be hearing from Professor Burra.
Ladies and gentlemen, I really would like to thank Professor Blumberg for her kind invitation. And I really think that this opportunity, I'm really very pleased to be to participate in this webinar, which explores, let's say, the impact of COVID on a very international level. The next one, please. And since I have to report something about Europe, this is the international survey that was organized by Dr. Avoglio, who sent the survey to more than 3,000 including transplant surgeons and transplant clinicians dedicated to solid organ transplantation. And the survey was divided into 3 sections. One was dealing with demographics, the other one with overall the transplant activity during the pandemic, and then some technical domains. But it's interesting to see on the answer to this question, should transplant activities be paused? And in Europe, overall we had 1,800 answers, let's say. And in Europe, 11% of the participants say that it would be not at all stopping the activity. Whereas on the opposite, 30% of them would completely stop the activity, and the majority, of course, were selectively stop the activity. But I found interesting another, next slide, please. Another question, which was, would you like to shift the resources to COVID-19 patients instead of keeping the resources for the solid organ transplant activity? And as you can see, I took the Italians as an example, being Italian, that strongly partially disagree 22% of Italians, whereas strongly partially agree 89% of Americans. And as we heard already during this webinar about the heterogeneity of approach and probably also action to be taken. And it means also the allocation of resources will be different according to different countries, and probably within the same countries also among different centers. The next one, please. Thank you. I think we already said that the data on the impact of this infection of the COVID-19 pandemic on the waiting list are really quite poor. So there are few studies that I selected for this presentation. This comes from Italy, Irene Bellini from Ison. And the authors look at the number of patients in the Italian waiting list for solid organ transplantation. As you can see, they drop only partially from nearly 9,000 to 8,500. And as expected, for liver, heart, and lung that are considered to be the life-saving organs, the waiting lists really were not significantly affected due to the fact that these kind of transplantation are considered to be urgent procedures that cannot be postponed. However, the next slide. If we look at the comparison with the kidney, so in this figure, you see the second row, which is the red row, comparing to the black one, which is the overall, and then liver and heart. But stay on the kidney row. It shows that this was the one most affected. Let's say that in the last 5 years in Italy, the number of candidates in the waiting list for the kidney were 7,000, quite stable. And in the last, in this period with the lockdown, they dropped to 6,000, meaning 50% less. And if we look at the peak of the patient that needed to be hospitalized in red, there are also patients that needed to be intubated with the ventilation, with the mechanical ventilation. This peak mirrors exactly the drop of the transplant activity. Next slide. And looking at another study, again in Europe, Europe is a small country. This is the study from the Netherlands, where they look at the waiting list of liver transplant recipient and the waiting list for kidney transplantation. This is interesting to see that they compare the months before the lockdown and a few months at the time of the lockdown. And what's it's clear from this slide, you see that they divided the transplantable and non-transplantable patients. The transplantable are in black, the other one is non-transplantable and in gray. And as in few weeks after the lockdown, as you can see, the two curves cross, and the number of non-transplantable patients were due to the progression of the disease, a deterioration of patients. They were too sick to be transplanted and then removed from the waiting list. Next slide. Even more, let's say, alarming is what's happening in the renal transplantation, when the list we're seeing now by Dr. Ratner, the example of kidney waiting list in US, in a center in US. And here is clear that, again, comparing the few, not really a few months, few weeks after the first case of COVID in the Netherlands, they observed a very high number of patients that died for different causes. This is reported in the gray column, and for mortality deterioration in a patient on the waiting list in the black one. The next slide. And the other point is when the patient on the waiting list gets infected. And this, I took the opportunity for the paper that John already presented from his group, but I extrapolated the data relating only on the waiting list. And in fact, it's absolutely very interesting to see that the risk of testing positive for the solid organ transplant on the waiting list was 3.8. The all-cause mortality risk was 10.2, and the median duration between the tests resulting positive, and that was 10 days. And that's already, we understand that we have really a different risk of infection by organ type. In this paper, they show that the highest, let's say, infection rates were seen in patients waiting for pancreas and kidney, for the small bowel transplantation, and for kidney. And in fact, the rate of infection is between 4.4 to 6.2, much higher comparing to the overall positive tests that were seen 3.8 for the entire population. The next slide. And coming back to the whole Europe, but this is another survey that was performed trying to get information from either recipients and candidates. That was organized by ELITA together with the LTR, European Liver Transplant Registry. They sent a survey to 141 liver transplant centers. This is on liver. And 109 centers reply, and they are distributed in 28 countries in Europe. The next slide. What they show on the right side, you see the evolution of the COVID infection in patients on the waiting list, and which are reported in the blue bar. So at the end, they found that 57 out of 5,400 patients on the waiting list, so meaning 1.0%, became positive. But it's interesting to see the range from 0.5 to 20%, very different across the different centers. And also the same was seen on the right side of the slide from the ICU admission, an average of 14%. But you see some countries such as Germany, the Netherlands, Belgium, you have to look at the green bars for the candidates, didn't report any ICU admission, whereas there were 8 and 9 in France, and then in Italy, 25, so increase in UK, and 50% in Spain. So again, confirming the different probably impact of the COVID, but also the management of those patients in different countries. The next slide. So if I may conclude by reporting what I believe are some constructive thoughts for the discussion, surely the impact of the infection, as far as I've seen, looking at the different data from Europe for patients on the waiting list, is really different by organ type. Also, the management of the waiting list during the pandemic presents some variability between, as I said, countries and probably also centers. The consequence is that the allocation of resources will be different in different countries and in different centers. And I like this sentence from the paper I alluded to before, that we really desperately need to have high quality data on the outcomes following SARS-CoV-2 infection in waitlist patients. It is really essential for clinicians and for the patient to make informed decisions. And I would like to thank again Emily and all the organizers for this kind of invitation. Thank you.
Great, thank you so much. And we're going to move on to our next talk, which I think as healthcare providers and professionals, we're all very interested in, which is the impact of COVID on burnout in the workforce. And Dr. Jesse will be presenting that talk.
Thank you again, and I want to echo everyone's gratitude for hosting this. Next slide, please. No conflicts of interest or disclosures. Next slide, please. Now, just like medical outcomes, we are only beginning to understand how COVID-19 will and has affected our healthcare workers and our broader systems. We are already seeing, however, a surge in burnout and other negative outcomes. Now, burnout is quantified, or is a syndrome that is quantified by feeling overextended or drained, which is emotional exhaustion, depersonalization, which is indifference or feeling maybe cynical or acting hostile, and lower personal accomplishment, meaning not feeling as effective or efficient in what we're doing. And as I said, we're already seeing evidence of increases, and that's not just cross-sectional data, that's actually also longitudinal data. So in non-transplant healthcare providers, there were several data collections that were going on as part of just an ongoing interest in healthcare provider functioning that had collected burnout data in 2019. And then the investigators wisely decided to collect data again in the context of COVID-19, and they saw huge jumps in burnout in our healthcare providers. So this is not just, it's not just cross-sectionally experiencing, but also we're seeing this evidence. However, next slide, please. However, what's important about this is that it's not just burnout. Before COVID-19, I give the context of moral injury, and how before COVID-19, I was invited to give a talk, and I had spoken with some military personnel, and they were a little irritated with, some of the symptoms that medical providers were talking about. But now they're not as worried. They understand more. In other words, we're seeing more from a trauma response perspective in our healthcare providers than we have in the past. So burnout was already prolific, but now we're actually seeing greater insomnia, depression, anxiety, and post-traumatic stress disorder symptoms, as well as alcohol, substance abuse, and even suicidal ideation. Now, again, we're just starting to learn about what that looks like in our healthcare providers. However, there are a few consistencies that have emerged in the literature. So one is, not surprisingly, exposure, both in frequency and duration of caring for COVID-19 patients. In other words, the more COVID-19 positive patients a provider cares for, and the longer they care for those COVID-19 patients, the greater they're more likely to have burnout or other negative outcomes. Also not surprising, lack of PPE and general equipment. So in other words, when providers not only don't have the equipment they need to protect themselves, but also to care for patients, they're at a significantly increased risk for negative emotional outcomes. Other predictors that have emerged include isolation, stigmatization, and abandonment. Those were found in other pandemics, such as Ebola, and then also significant fear of infecting the loved ones. Now, again, we are in a situation where we don't know how this is going to look in a long-term sense. So as providers and individuals, we need to think about how we can prevent negative long-term outcomes and protect positive or encourage positive ones. Because I don't want to say it's all bad. Our healthcare providers have shown incredible resilience and adaptability in a lot of respects, but that does not mean that this hasn't been hard on us. Next slide, please. Now, what we first have to do is we have to acknowledge, one, that there is a problem, that this has been difficult, this has been hard, but also that the solutions are not easy. So when we look at the broader burnout literature, a lot of it's focused on the individual level. In other words, teaching the individual strategies for mitigating stress and managing stressful demands and things of that nature. But that's only so effective. We need to think about this not only at the individual level, and this has been the call across all researchers and clinicians who live and work in this area, but we need to think about this not just at the individual, in other words, strengthening the individual, which is great, but if you strengthen the individual and throw them back into a war, they're still exposed to extreme stressors. So we need to think about this across the healthcare system, the broader national and international settings, but we also have to think about this across time. Next slide, please. Now, at the individual level, I will say, leadership and systems, one of the best things that leaderships and systems can do is to encourage cultures that encourage self-care in the individual. So in other words, at the individual level, it is important to practice self-care. And I put a couple up there, but what I want to emphasize here is 2 or 3 different things. One, at the individual level, I always encourage people to find what resonates with you. In other words, we can teach you mindfulness and acceptance-based. We can teach you other strategies, and that's great. But everybody responds a little bit differently. I always joke, one of my mentors was a huge yoga fan, and I can't stand yoga as an example, but I like mindfulness. So the point being is that everyone should have the opportunity and space, and leadership should encourage individuals to take the time to explore what resonates with them individually. And to apply that and have that accessible. Also at the individual level, I would encourage everyone to recognize, one, in themselves and forgive in themselves when they are struggling, but also not stigmatizing other individuals who maybe are reaching out or maybe appear that they may need help in reaching out. In other words, struggling in these stressful times is not a sign of weakness or a personal flaw. I think we've made some progress in that area, but as a culture, and especially in the healthcare culture, where we're such high-functioning, high-performing individuals, we still struggle with that at greater levels than a lot of other folks do. Next slide, please. Now, from a leadership perspective, and this is where we really need to have our leaders come together and have this conversation, because this is where it needs to start, quite frankly. We need proactive leadership support, and that includes both subjective. In other words, leaders need to take steps and actions that appear to be supportive, but they actually have to do things that are supportive as well. And that includes things like providing mental health resources, and maybe that's about new strategies for financial compensation. Some of the stuff Marwan Abajud is doing at the STS and working on some of the wellness initiatives are just perfect examples of what I'm talking about. There's also empirical evidence to suggest that there are things that individual centers can do, such as a chief wellness officer. Now, what's important about the chief wellness officer is that it's not just about having the figurehead, but it's also about giving them some of the autonomy and resources they need to be able to accomplish some of their goals. But again, there is empirical evidence supporting that chief wellness officers can be effective in centers. And the AMA provides a really nice roadmap if you have one. Now, also, it's important for open communication channels. And this, again, empirical literature, this is all supported by the empirical literature. So in other words, balancing sugarcoating with catastrophizing can be a little bit of a talent in our leaders, but having where leaders are perceived to have open communication channels, are trying to foster resources and provide resources, and appear to be fostering a sense of community, then the individual at the individual providers report greater confidence in the healthcare system and feel more positive about their role in the system. Next slide, please. And then at the broader community, I should say community, national, and international level, we need to advocate for, and this comes from the individual, the organizations, and also healthcare systems leadership, is advocate for and allocate funding to do these things, but also to have a better understanding. COVID-19, just like, again, we're just beginning to understand how we are responding to this from our own emotional processing. And I, in the sense of, one of my roles is directly involved with residents, and it's definitely impacted them in very prolific way, very profound ways. So we need to have a good understanding so that we can develop targeted interventions and targeted changes to our broader systems to protect healthcare workers over time. And also something that's not talked about as much, but I think is really very important, is we need to continue efforts to recruit individuals into healthcare careers. I think that I don't know how this is going to impact the individuals going into healthcare careers, but we know we have shortages in certain very important roles. And so we need to recruit individuals within our communities and encourage individuals to become healthcare providers. One of the main areas I advocate for this for is individuals in mental health. We don't have enough psychiatrists, but even in the general medical side of it, we don't have enough primary care providers. We need more community health outreach providers, but we also need systems that reimburse for them. So there's a lot of work we can do here that would, it seems like it will have a direct impact on our patients, but also could have potential positive impacts on our providers. Next slide, please. Now, I could have provided a lot more resources here, and I definitely welcome anyone to contact me if you're interested in additional resources, because we have many, but these are two that I think are particularly good, both for an individual, but also for a system level. The National Academy of Medicine has just go on, and if you're interested, it offers a lot of individual recommendations and resources, but it also offers a lot of direction if you are trying to improve this at the system level. And then COPE Columbia is one of the better, I think, community-facing but academic resources for healthcare providers on managing stress and strain in the context of COVID-19. I thank you again so much, and I appreciate this presentation.
Thank you so much. And I'd like to thank all of the presenters in the first half of this webinar for really outstanding and very informative presentations. And in the interest of time, we're going to go right into our second half, and Dr. Deepali Kumar will introduce this session. Thank you.
Thank you, Emily. My name is Deepali Kumar. I'm Professor of Medicine at the University of Toronto in Canada, and I will introduce our next set of talks, which will deal with the current and future state of transplantation during this COVID pandemic. Our first speaker will be Dr. Atul Humar, who is the Chief of Transplant at the Ajmera Transplant Center at the University Health Network in Toronto. He'll be talking about strategies for doing COVID care and non-COVID care simultaneously. This will be followed by Dr. Fausto Baldanti, who is at the Department of Clinical, Surgical, Diagnostics, and Pediatric Sciences at the University of Pavia in Italy, in the Molecular Virology Unit at Policlinico San Matteo. He'll be talking about testing strategies and time-based clearance for those with a history of COVID. After that, we'll have Dr. Mike Ison, who is professor at the Division of Infectious Disease and Organ Transplantation and director of the Transplant and Immunocompromised Host Infectious Disease Service. He's also the director of NewCat Center for Clinical Research at Northwestern University Feinberg School of Medicine in Chicago. And he'll be talking about antivirals and immune modifiers for the treatment of COVID. And then finally, we'll have Dr. Cameron Wolfe, who is Associate Professor of Medicine and Infectious Disease at Duke University Medical Center, who will be talking about the future of vaccines and how vaccines will impact our transplant candidates and recipients. So let's get started with Dr. Humar.
Thank you very much, Deepali, and thank you to Emily and Deepali and all the organizers. I'm really honored to be able to speak today. Just as some background, Canada has socialized medicine and universal healthcare. So we're kind of constrained for resources even at the best of times, and certainly in the era of COVID, we've really struggled with hospital capacity and resources. And this headline, the province I live in is called Ontario, and this headline was back almost a month ago, where hospitals were already bursting. And then I have to admit, I was somewhat pleased that we were the headline city in CNN when we went into a lockdown not that long ago as COVID infections soared in Toronto. Next slide. So when you're considering doing transplant activity, and really we're talking primarily about fresh transplant activity in setting of a COVID pandemic, here are sort of the things that you have to take into account. So the first is transplant related activity. So this is new transplant surgical admissions. Then you have transplant patients admitted with COVID. You have non-COVID transplant readmits. So they're admitted for some other issue, like a rejection or infection. And then you have the whole ambulatory part, the transplant follow-up and the pre-transplant assessment. And then in your hospital, you'll also have non-transplant activity. And this is other surgical activities such as cancer, cardiac, neurosurgery, etc. You'll have the medical activity, which can be non-COVID, and then you'll have a big chunk of COVID activity, which, as we know, has the potential to rapidly overrun ICU capacity and inpatient ward capacity. Next slide. So how do we protect and continue transplantation, and especially in a resource-constrained setting? And one of the things we did in Ontario is all the transplant centers approached the Ministry of Health, and we asked them to give this directive to the CEOs of all the transplant hospitals, and it was quite well received. So the directive was really, organ donation is a rare life-saving opportunity. It is not deferrable, and each organ that is not transplanted is lost to the potential recipient forever. And this really gave directive to all the CEOs of the transplant hospitals. And our rationale that we provided to the ministry was that not only is the organ loss an issue, but with adequate donor screening, you can really prevent donor-derived COVID. And if you take appropriate measures in the hospital, you can bring patients safely in for a transplant without really increasing the risk of getting COVID. And then once they're transplanted, they can take precautions in the community. And what we've seen and what was presented earlier is that the disease severity drivers for COVID are really often other comorbidities and age rather than immunosuppression, perhaps with the exception of lung transplantation. And then the other thing, as we've heard, is that you have to balance not doing transplant versus wait times and death on the waiting list. And certainly in Ontario, like other jurisdictions, in the first wave, when we deferred kidney transplant, we saw a lot of dialysis patients get infected with COVID. So based on these recommendations, really all hospitals in our province have agreed to prioritize and maintain transplant activity, which is which is quite a feat because it's often at the cost of other programs which have had to scale back activity. Next slide. So here are some important principles for carrying out transplant activity, and even if you have a lot of COVID in the community. One is to ensure the risk of iatrogenic COVID exposure is minimized by developing local COVID-free pathways, and this includes a safe set of transplant-specific processes like personnel, diagnostic imaging, lab testing, clinics, etc. Ensure both donor and recipient pre-transplant COVID screening. Ensure the processes are in place to protect procurement teams. So for example, not sending out our teams into hospitals that have current outbreaks going on. Ensure individual patient risk benefit assessment and appropriate informed consent. And then finally, we really need to be mindful of the risk to living donors and I believe, take extra precautions there. Next slide. So this is what we've done in our hospital. And just to give you a background, we do about 600 to 700 transplants a year. So we're a fairly large transplant program, and we've kind of compartmentalized our workflow. So we have a separate ward for patients who need fresh transplant patients, and they go to a separate area in the ICU. And then we have a separate step-down unit just dedicated to the fresh transplant patients. And then they go to our fresh transplant ward, and then hopefully they go home. And then we have a separate ward for transplant patients with COVID, and they're cohorted actually with other patients with COVID as well. And then we have a third separate ward for transplant patients who are readmitted from the community for non-COVID reasons. And so we've tried to compartmentalize these three areas as much as possible. Next slide. So with this, we believe that it's safe and reasonable to try to continue carrying out full capacity transplantation. So we develop COVID-free zones for fresh transplant activity and living donors. Ideally, the transplant units should all be single occupancy, and I know this is probably pretty standard in the United States, but it's not really standard in Canada. All transplant patients and living donors admitted to the hospital should be screened for COVID regardless of symptoms. So we don't admit anybody unless they've had a COVID swab on admission. Dedicated teams, adequate personnel, heightened infection control practices are all important. And then for the post-transplant side, we've shifted our ambulatory to virtual as much as possible. Next slide. And these are some of the necessary resources that you need to be able to carry this out. So you need OR availability, ventilator, ICU capacity, blood bank dialysis. You need residents, fellows, medical and surgical nursing, and other staff free from other duties to focus on transplant. And you need adequate levels of healthcare worker staffing. And actually, this has been our greatest challenge. And because of healthcare workers being off sick or being off because they've been exposed to somebody with COVID, we've had a real challenge in staffing. And then, of course, you need adequate testing resources and adequate PPE. Next slide. So this is my final slide. So what happens when conditions explode and then you really have to curtail transplant activity? So what we've done is we've established agreement across all the transplant centers in Ontario of this green, yellow, red system. So green is where all programs are open, and we're currently all in green despite quite a bit of COVID activity in the community. And then yellow, we would allow programs to restrict. We'd still offer all the deceased donors, but we'd allow programs to restrict recipients so they might not do living donor kidney, for example. And then red, programs would generally be closed except for the highest risk liver, lung, and heart transplants, and possibly some highly sensitized kidney transplants. Next slide. So with that, thank you very much. And once again, thank you to the organizers.
Go ahead, Dr. Baldanti.
Okay. So thank you, Professor Blumberg and Professor Kumar, for the kind invitation. So may I have the first slide, please? Okay, so to fully understand how this virus works, we have to understand the distribution of the receptors. So we know there are two different receptors, so ACE2 receptor and TMPRSS2, that both are important for the virus to enter the cell, and the distribution is quite broad in the body. Of course, lung, and the lung is, of course, the first hit of this virus with this bilateral interstitial pneumonia. But next, please. May I have the next slide? Okay. So in the lung, what is happening is that we might have a different virus population than we observed in the nasopharyngeal swab. This is somehow explaining how in patient with bilateral pneumonia, sometimes the nasal swab is negative. It's like the virus gets in through the nasal cavity and then goes deep in the lung, and we lost the signal from the upper respiratory tract. So whenever we see a pneumonia, just don't stick only to the nasal swab results, because can be misleading. And the virus that is present in the lung is evolving in a different way, so we can find some small changes at the nucleotide level that is testifying that there is an evolution, local evolution, and possibly related to the clinical evolution. Next slide, please. So now we have this slide showing that the virus is not only sticking in the blood, in the lung, but through blood or other cells, maybe macrophages, is traveling to the heart. And you see here myocarditis in a young boy, and also myocardial localization in an elderly with a cardiogenic shock. You can actually see the full viral particle. Next slide, please. So in another SARS-CoV-1 was also associated with shedding through feces, because the replication was taking over also in the intestine. Also in with SARS-CoV-2, we can see some patient shedding virus through present in rectal swab, but is a minority of the cases, so is 10% of all positive cases. These were people in the ICU ward. Next, please. So the young and the very young are not affected that much on a clinical level. They can shed the virus, can get infected, shed the virus, also in a high amount, but at least on acute phase, in the acute phase, they don't have very much a severe COVID disease. So the severity is concentrated in from the 50s up, with an increasing by decades. Next, please. Okay. So what is happening in a single patient, at the single patient level? So, well, we have a 1 week more or less incubation time, 1 week when the patient is highly contagious and with a very high amount of virus in secretion, nasal secretion, and the nasopharyngeal swab. So PCR is positive, but also viral isolation in cell culture is easy and positive, and with a high amount of virus that is shed. This lasts for another weeks, more or less, or 10 days, and finally antibody can be detected. There is no real difference in time with the appearance of IgM and IgG. They arise simultaneously, let's say more or less simultaneously, and at that time we can see a decline in the PCR levels in the nasal swab that are trailing off for a long period of time, also in immunocompetent individuals. So that can usually take a couple of weeks, but it can take 1 month, even 2 months. And this long trail off of the PCR signal is even more pronounced in transplant recipients. This is a common experience, but is this virus really replicative? Next. Okay, this is an example. Immunocompetent individuals with olfactory and taste disorders, and at the beginning, in the first week, when they are symptomatic, you can only see the virus in nasal swab and no antibodies, and there is a phase lasting 1 week. You have both virus and antibodies, but is already started the recovery phase, and at the very end, you only have antibodies and no longer virus. Not only on a qualitative level, but on a quantitative level, you can see increase in antibody titers and a decrease in, that is the middle right panel, and the bottom right panel, you can see a decrease of the viral load in nasal swab that is in parallel to increase of the antibody titers. Next, please. So, residual RNA in convalescent patient is not associated with really high level of replication. These are more or less 400 nasal swab in patients that were clinically recovered, but showing low viral load levels. There are 2 genes detected here on the right, in the middle panel, the first right panel, and you can see that more or less they have the same signal, vary over around the 35 cycle, the median. And on the right panel, you can see that the majority of them are isolation negative. So it makes up that only 2% more or less of the patients that are recovered and still positive by PCR, they don't carry infectious virus, actually. Next. Okay. So in these 2 studies, that are epidemiological studies that are focused on the first initial outbreak in Italy, so the Lodi red zone, the very first outbreak in Italy. So 23% of the individuals living there were seropositive for SARS-CoV-2, and the titers is in the left panel. In the right panel, there is a second study, including a larger area, testing more or less 2,000 blood donors. We could document about 20% of the positivity. So very high positivity in this area. And the antibody titers, actually, they don't decline so fast as it was told at the beginning. So they last for weeks, maybe for months. And in fact, there are the green and purple histograms that are the paired samples taken a couple of months apart. Next, please. Okay, and this is important because these are the neutralizing titer following either mild infection, the blue bar at the bottom, and following more severe infection. We can see that convalescent patient overcoming more severe infection, they have higher neutralizing antibody titers than patient overcoming mild infections. And this was important for selecting the best donors for hyperimmune plasma treatment. Next. Okay, so what about T-cell response? Okay, T-cell response is related to neutralizing titer, are the 3 graph at the bottom. But what is interesting, and this is the first upper left graph, is that even unexposed individual, they can carry a response. Next. Okay, and these are actually our own data. On the right panel, you can see the response in individual, the T-cell response in individual overcoming an infection. So we have a very high signal against S protein, M protein, N protein, whole virus lysate. But what is interesting in the left panel is that also unexposed individuals, 30% of unexposed individuals can have signals against these viral proteins. So this is a second level protection that is associated to neutralizing antibody, but is also independent and can also explain why this virus is so widespread, but also even in the very highest red zone is not affecting 100% of individuals. This is an interesting topic to further explore. Next slide is the last one. And in that slide, I would like to thank, of course, my group and my resident, and also again the organizer for inviting me to this webinar. Thank you.
Great, thank you so much, Fausto. We'll move on to Dr. Ison.
Great, thank you, Deepali and Emily and everyone that's participating in this. I'll move pretty quickly through antivirals and immune modifiers for the treatment of COVID-19. There's a fair amount of data, some of which is conflicting, but very little in transplant patients. These are my disclosures. Next slide. So we currently have a number of different approaches for the treatment of COVID-19. These include agents that either purportedly or are antivirals, so they will slow the replication of the virus. The second group are for the treatment of patients where the viral replication is less significant, in which the immune response is the key driver for the pathology. There was a lot of enthusiasm for IL-6 inhibitors, as well as other targets to modify the host immune response. For the most part, unfortunately, these failed to demonstrate efficacy, and in the case of the IL-6 inhibitors, may be associated with no improvement or potentially worse outcomes in transplant patients. The one exception to this is corticosteroids, which we'll talk about a little bit in a few minutes. The last are antibody-based therapies. This can either be a polyclonal set of agents, such as convalescent plasma, or monoclonal agents, such as the Lilly and Regeneron compounds that I'll present some data on next. The first thing that I would recommend or I'd like to talk about, next slide please, is remdesivir. This is a direct-acting antiviral that inhibits the RNA-dependent RNA polymerase of COVID-19, or SARS-CoV-2. Next slide. The main evidence to support our use of this agent, as well as FDA approval, was the NIH adaptive COVID-19 treatment trial. And as a disclosure, I'm the chair of the DSMB of this. This included over 1,000 patients where the primary endpoint was time to recovery. So how quickly did patients recover? And this is where they either were discharged or in the hospital no longer requiring oxygen. Next slide. This study was associated with a 5-day reduction in time to recovery, which was statistically significant. Mortality in this study trended to improvement, but was not statistically significant. Next slide. Looking at subgroups, it appeared that the therapy was less effective in patients with more severe disease, most effective in those patients requiring oxygen, with less difference in those not requiring oxygen. Next. And so 2 open label studies were performed that filled out some of the data here. The first was the moderate COVID study looking at patients with pulmonary infiltrates and O2 sats greater than 94%. At the endpoint, day 11, day 5 days worth of remdesivir showed better recovery than standard care alone. Day 10 wasn't statistically significant, although numerically better. Unfortunately, over time, beyond this day 11 time point, there was less difference between the 2 arms. And so the authors concluded that there was benefit in this population, but the benefit was modest. Next slide. Going on to the next slide, sorry. The second open label trial looked at patients with more severe disease, lower oxygenation, and again, randomized 5 to 10 days. Only those patients with more severe disease benefited from a longer duration of therapy. And again, this wasn't a traditionally randomized placebo-controlled trial, so whether or not there's additional benefit with this additional therapy is still a little bit unclear, but our current guidelines recommend longer therapy in patients that are sick or progressing despite 5 days of therapy. Next slide. There's been a lot of focus on the Solidarity trial, and some groups have removed remdesivir in terms of their guidance for the use of this. Next slide. This study failed to find a mortality benefit, and I think it's aligning very well with the the Act 1 study. This is now out. It was published this morning in New England Journal. There wasn't a difference in hospital discharge, but again, this was an open label study where 10 days of remdesivir was given to patients. And since this was a global study, the time to discharge may have been restricted by local policies as well as a desire potentially to complete the therapy. So I'm not sure that this seals the deal on remdesivir, and I do think that there's still evidence to support its use. Next slide. The real question is, does it do what we think it is? Does it affect viral replication? And unfortunately, the only study that has presented this data is the Chinese study, which was underpowered. And really, there was no difference in upper or lower respiratory tract samples. This is important, next slide, because we really have to understand, is there a benefit beyond mortality, which I do think that there is, but we need to know supporting data to support whether or not remdesivir is effective. If we don't see virology, and if we don't see changes in biomarkers, it really raises the question of whether or not this agent is as effective as we thought it was from the ACT trial. The other thing that we don't know is resistance to challenge. This is a concern in our transplant patients, as well as those that are getting shorter courses of therapy. And I think the question that I have is, since we have very limited data in immunocompromised patients, do we need longer durations or different approaches in these patients, particularly when dexamethasone is being used? We've seen at least 3 patients that have improved while on a short course of remdesivir, only to return to the hospital and go into the ICU with severe progression of COVID-19 with very high viral loads. So again, raising the question of activity. Renal dysfunction is currently a challenge with this therapy in the package insert, but increasing data suggests that there may be safety of using this in very short durations in patients with renal dysfunction. Next slide. There was a lot of effort, as I mentioned, focused on immune modulators. Despite a lot of enthusiasm, most of these have failed to demonstrate clear utility. Baricitinib has an emergency use authorization based on a relatively thin population achieving benefit, and whether or not this expensive drug is better than the use of dexamethasone is something that will be studied in Act 4. Next slide. Steroids, particularly dexamethasone, were studied in the recovery trial and were associated with improved survival in those patients requiring oxygen or requiring mechanical ventilation, but is associated with worse outcomes in those patients not requiring oxygen. Whether or not this is needed in our immunosuppressed patient population really is an area where I think we need to fully understand what the situation is. There are some that think, I think rightly so, that if the patient is having progressive disease based on their underlying immunosuppression, perhaps enhanced immunosuppression may be needed with the dexamethasone in those patients. Next slide. This has been shown to be true for other steroids as well, and so while most will use dexamethasone, other steroids appear to have similar benefit. Next slide. Antibody-based therapies are kind of the next wave, and again in the United States we have an EUA for convalescent plasma as well as 2 monoclonal antibodies. Next slide. But I think that the data on convalescent plasma is really quite questionable. Last week, this well-done randomized trial from Argentina was presented and really failed to show any improvement in terms of ordinal scale, mortality, or improvement in patients over time with the use of convalescent plasma. This included a relatively small number of patients with very early delivery, and so this may be an area that warrants further investigation. Next slide. Monoclonal antibodies we've heard a lot about. These impact the spike protein in a number of different places as shown here. Next slide. And we have 2 sets of monoclonals. The bamlanivimab, which has been published in the New England Journal, was associated with slightly more rapid recovery in one of the dosing arms compared to placebo. Next slide. As well as improved recovery from a symptom standpoint and a reduced rate of hospitalization with early therapy. Next slide. The second set of agents, casirivimab and imdilivimab, is a combination agent which has been associated with more rapid clearance of virus, as well as reduction in the risk of hospitalization, with a higher risk in the high-risk population, those with multiple underlying comorbidities. And again, these therapies haven't been studied very much in the transplant population, should be relatively safe. And I think a transplant population may be one where there may be benefit in using these therapies. Resistance emerged more frequently with the Lilly compound, and so perhaps the combination regimen may be more appropriate in the transplant population. And with that, I really appreciate the opportunity for rapidly running through this data, and I'll turn it back over to our next speaker.
Thanks, Mike. So we'll go on to Dr. Wolfe.
Hey, thanks so much for everyone to make it through to this point, and I'll try and bring it home. So next slide. Here are my disclosures. They don't have anything to do with COVID vaccines moving forward. A bit of a US-centric slide to begin with apologies to an international audience, but I want people to be clear that this is a pretty fast-moving space for us. So, as you probably know, we have 2 vaccine products that have now gone forward to the FDA for FDA approval and emergency use authorization. This comes on the back of the UK, in fact, forging forward and approving for early release for the Pfizer vaccine just a number of days ago. So I want people to start off by being pretty clear that this is going to be front and center of your patients' discussion and your colleagues' discussion over the next couple of weeks as this rollout occurs. For us here domestically in the United States, if, as we would anticipate, the FDA grant an EUA on the 10th, that would then go to the CDC's Advisory Committee for Vaccine Practice, who guide and in fact have already given preliminary advice as to how they'll prioritize the vaccines that are approved. And really within 2 weeks, many of our hospitals will have had pre-deployed Pfizer, we expect, vaccine doses and will begin vaccinating. And so with Moderna approaching through the FDA shortly thereafter. Next slide. So this really is front and center on many of our minds, and I wanted to start by giving a little bit of background data as to what the phase 3 trials have shown, recognizing that this is incomplete data and I don't have all of the full details that will be ultimately visible to the regulatory authorities at this point. But what we know so far, and this is a summary put together of a number of different publicly available data sources. The Pfizer vaccine really has, to me, very good vaccine efficacy. Let's state that to begin with. I would have been very satisfied with a 60 to 70% efficacy of protection, and yet we're talking 95. And so 95% protective efficacy from a 2-dose vaccine. It's an mRNA vaccine, and to be clear, this is the first, along with Moderna, these are the first vaccines using that form of technology. This is really an outstanding achievement to get these vaccines essentially ready for deployment within the space of a year. That is an outstanding scientific achievement, to be blunt. And yet the benefit here is impressive, because not only do we see a pretty dramatic reduction in the number of cases, but we also see that even those who ended up with severe clinical cases were almost all 9 out of 10 in the placebo population. What we don't know with these trials is, was there asymptomatic transmission or acquisition of infection, occurring in the vaccine arm? Were people in the vaccine arm still capable of spreading the virus? We don't know that yet, although I think the assumption would be that if clinical cases are down, likely the transmissibility from vaccinated people would also fall. The disadvantage up front with the Pfizer vaccine is a very challenging cold chain issue, where it needs to in fact be kept at sort of -70 to -80 deep freeze until a matter of hours before its deployment, which obviously limits its use to many of the hospitals and large research institutions where we all work. From a safety point of view, a well-tolerated vaccine, a number of people, perhaps 10 to 20% of folks would get sort of typical vaccine side effects, particularly after the second dose, so some fevers, chills, myalgias, fatigue for sort of 12 to 24 hours, similar in many regards to what I would ascribe to a shingles vaccine for our over 50. So next slide. Importantly, no stopping signal for either of these vaccines that cause them to have a pause. So Moderna, similar vaccine technology. We know a little bit more here about some of their data. Again, comparable vaccine efficacy. I really sort of view these as functionally the same in that regard, but a couple of differences. So this was a 30,000 person trial, similar number of folk, as you can see there, who developed COVID. The cold storage here is markedly easier. It does need to be refrigerated down to -20, but actually has if you think about the locality of refrigeration at that level, we expect refrigeration and cold chain to be far easier here. And in fact, at least within the United States, this will be expected to be prioritized to health departments as opposed to, say, universities who have -80 capacity. We do know a little bit about the intentional diversity breakdown here, both for Moderna and Pfizer was quite similar. I think pleasingly, given our patient population in a transplant realm, this was intentionally tried to be administered in phase 3 studies to quite a wide racial and ethnic blend within the United States, perhaps much more representative of our patients in transplant than we would usually see from vaccine trials. Move forward. But if you get in specifically to transplant, I think the one key here is that we don't know the exact transplant experience. So particularly with Moderna, you can see the cut and paste exclusion criteria from their phase 3 trial here. And similarly, Pfizer intentionally, both of these groups did not enroll immunosuppressed individuals. And that's very clearly done with intention, and I agree with it. It's designed in a phase 3 trial to understand T and B cell response and antibody production. But of course, it leaves us a little blind as to what the true impact of these vaccines will be in our population specifically. Move forward. For completion, and this will obviously be variable depending on which part of the world you're listening to this, there are a number of other vaccines that are in phase 3 trials. The AstraZeneca and Oxford University one certainly moving the furthest along, although some other technologies here, including protein subunits and viral vectors, also moving forward. And we would probably expect a number of these to reach government authorities for consideration of purchase in the upcoming months. Next slide. So what does this mean for transplant? And I'll concede when n equals 0 of transplanted patients who, to my knowledge, received either of these upfront vaccines, this is my interpretation and how I'm approaching this decision-making for patients that I see. But I want to sort of lay it out as a bit of a pro-con, and I'm happy for folks to have their own impression. I think the pro side for early vaccination for our transplant candidates is pretty clear. At least in the United States and certainly elsewhere, the pandemic is increasing, and we've seen a large number of our transplanted individuals unfortunately fall sick with COVID many of whom have a poor outcome, as others mentioned earlier. It's a highly efficacious vaccine in the healthy population. Will that translate to the our immunosuppressed individuals? It may not as much, but it may not need to as much to still have a significant impact when the incidence of COVID is rising here so significantly. And that's certainly been true when we think of other highly efficacious vaccines such as Shingrix. They may not have quite the impact in a solid or liquid organ tumor population, but they're still very effective and we use them widely. And I think in terms of side effects, so far, we haven't seen any that were significant in the general population. It always raises an interesting question in transplant of whether these highly immunostimulatory vaccines will in fact translate to greater rates of rejection in our transplanted population. I want to talk about that a little on the next slide. But so far, I think that needs to be balanced against the implications of a very inflammatory virus for our patients as well. And certainly in our lung transplant patient population, for example, I dread the late incidence of CLAD in people who have a very sort of pulmonary inflammatory process as a result of their infection. We don't know anything about pediatrics. They were excluded from these trials at this stage, although Pfizer is certainly now exploring in age down to 12. We don't know anything in the general population about durability, and I think it's incumbent upon us to be really transparent with our colleagues and patients that that is true. I do not know if the protective efficacy here will be for 6 months or 6 years. We just haven't had enough experience to possibly know that. But again, in the face of a significant wave of cases, that may be, frankly, less relevant. And then the other question that we always pose, of course, is, well, what is the ideal timeline for someone who's just been or about to be transplanted? These are both 2-dose vaccines. And so, is it reasonable in someone who's very high risk for COVID but about to be transplanted or is active on your wait list, should you give them the first dose and anticipate that maybe they may be listed shortly thereafter or transplanted, is something that we're going to have to learn about. Let's move forward. So I want to come back to the vaccine safety question because I've already received this from a number of colleagues. And some of this came up, I think, after some 2009 data that hinted that there was extra development of de novo anti-HLA antibodies after influenza vaccine. And so that sort of sparked a lot of interest in this area about a decade ago after the H1N1 pandemic, and yet really has not been seen, to my knowledge. And in fact, some of the folk here on this call led many of these trials. Has not borne out since. And in fact, careful examination of sort of rejection enhancement, if you will, from Shingrix, in fact, over recent years, has really not shown that to be an issue. So although I think the theoretical concern is real, and I think we need to be cautious about using mRNA vaccines that have not been used in transplanted patients before, again, when you put this in the context of the risk of the rejection that COVID itself may in fact trigger, I fear, to me, it seems to be a clear balance in favor of vaccination. Move forward. So again, US-centric slide, but relevant for everyone to understand. Those of us in healthcare who see COVID patients on a regular basis, please recognize that in likelihood in the next couple of weeks, you will receive calls from your hospital to start coming forward if that's something that you choose to do. You'll see here that in phase 1B, however, we also have immunosuppressed patients, including transplanted patients. This is the North Carolina version of the prioritization list, although this represents a quite similar picture to what many of you will all have from each of your own states. So I think the take-home message here is that if you're not thinking about vaccination and how you discuss it, you really start to need to, because this will become an active question for your colleagues, for yourself, and then very shortly thereafter for your patients. I think really hopefully in the next week, in the next month or two. Move forward. So I'm going to end by just concluding. We're about to face what I'm very hopeful for is a light at the end of what has been a long tunnel. We have 2 very effective vaccines about to grant approval here in the United States and already getting approved elsewhere. This will have a significant impact on our colleagues, on our patients, and folks on the waiting list. And although it is a data-free zone in terms of how this directly benefits our transplanted group, for me at least, this tips pretty heavily in favor of giving vaccines when we assess the time is right and the delivery is available in sufficient numbers. I'd be happy to go into that in more detail if folks want offline. final call. There's a wealth of opportunity here for multiple site research based on durability and efficacy and frankly rejection that's unique to our transplant population that we just have to learn about. So thanks again for the opportunity to talk, and I'll hand it back to the organisers.
Thanks very much, Cam, for that great presentation. Unfortunately, we are over time, and so we won't have time for questions. I hope that many of the questions that those of you listening submitted were answered in these talks. I'd like to thank all our speakers for fantastic presentations. I'd like to thank my co-moderator, Dr. Blumberg, the organizing committee, and the technical support staff. I'll mention that we will be posting the recording of this presentation. It will be available online on the AST YouTube page and the UNOS COVID page, so you can listen to it at your leisure later. So thank you very much for all of your attention.